We explained the PK/PD of vancomycin and determined a loading dose in critically ill patients. We also determined IDSA guideline concordant empiric vancomycin therapy. Now the next learning objective is given a patient with a suspected MRSA infection, determine an empiric vancomycin maintenance dose and frequency based on population pharmacokinetics. So when it comes to population kinetics, the purpose is, of course, is to determine dosing regimen of vancomycin based on therapeutic targets and population parameters. So we're making assumptions from these models, from these pharmacokinetic models. The first assumption is that whoever the patient is, it actually fits the population parameters. And of course, we're making assumption that the patient is not on dialysis and the patient is not volume overloaded. So some examples of exceptions to population kinetics includes end-stage renal disease. So these population kinetics don't apply to end-stage renal disease. They also don't apply to heart failure exacerbation. They do not apply to anosarca, which basically means volume overload in the entire body. Ascites, which happens in patients with cirrhosis, so that's also fluid retention, and cystic fibrosis. So all of these affect fluid status of the patients, which affects vancomycin volume of distribution. So, when it comes to population kinetic, of course we have the population. The problem is these models are basically derived from a sample of the population. So a group of patients are selected in a study, and then in the study, they come up with a pharmacokinetics model, and that pharmacokinetics model, of course, applies to that sample of patients, but the question is, does it apply to the rest of the population? So we have to be very careful when we use population pharmacokinetics. So one of the equations that's from population is vancomycin clearance. So vancomycin is actually eliminated primarily by the kidneys, and its clearance is correlated with patients' creatinine clearance. So about 70 to 90% of the creatinine clearance is actually vancomycin clearance. So we can actually use this equation that vancomycin clearance in liters per hour equals 0.8 times creatinine clearance, as long as creatinine clearance is in liters per hour units. And in order to get creatinine clearance in liters per hour unit, you basically multiply the creatinine clearance that you normally calculate from Cockcroft-Gault, you multiply it by 0.06, that gives you liters per hour, and then you multiply that by 0.8 to get vancomycin clearance. Now, of course, there are many other equations for vancomycin clearance. This is the equation that we're going to use in this class. So, other equations are also valid. So you may see preceptors who use different equations, and that's okay. The next equation is volume of distribution. Volume of distribution, although vancomycin is hydrophilic, it has a huge variability in volume of distribution. It goes from 0.4 to 1.0 liters per kilogram. And because it's hydrophilic, volume status makes a difference. So if someone who's dehydrated, the volume of distribution is lower. So it's closer to 0.4 liter per kilogram. Whereas in someone with fluid overload, because the volume of distribution would be higher, it's actually closer to 0.9 or 1.0 liter per kilogram. Now, the volume of distribution also depends on gender, age, weight, and renal function. So females, elderly, and obese patients actually have higher volume of distribution. And the lower the creatinine clearance, the higher the volume of distribution. So for most patients, we will use the volume of distribution in liters equals 0.7 liters per kilogram times total body weight in kilogram. However, this equation, you should only use it in patients with normal volume status. So if you've given a case, if the patient has normal volume status, you can use this. Whereas if someone is dehydrated, you should use something closer to 0.4. And if they have fluid overload like congestive heart failure, you should use something closer to 1. And again, there are many other equations for volume of distribution. There is no perfect equation. In this class, we will use this equation. You may work with preceptors who use different equations, and that's okay. So elimination constant. We actually are going to use the Motzke equation in this class. So this was derived from population kinetics, which is basically 0.00083 times creatinine clearance, this time in milliliters per minute. And then once you multiply that, you add 0.0044 to it, and it will give you K in inverse hours. And then of course you can use K to calculate half-life. And then you calculate tau. So for tau, you want to use your target peak and trough. Based on the infection, IDSA has recommendations of what your goal trough should be. So you either have a target trough of 10 to 15 for non-severe infections, or you have a target of 15 to 20 for severe infections. So you pick something in the middle. So if your target is 10 to 15, you can choose either 12 or 13 and put it in the trough. If your goal is 15 to 20, you can choose something like 16 or 17 here. And then for the peak, if you have the lower target trough, you can choose 30, and if you're and put it in here. And then if your target trough is 15 to 20, you can choose 40 and put it here. And it really doesn't matter what you pick for the peak. It's just to give you a more realistic tau number. And so once you calculate tau, you want to round it to something that's clinically meaningful. So for most people, Q8 and Q12 will be the the actual tau, as long as they have normal renal function. If they have renal dysfunction, you need to use even longer frequency. And some patients may actually need Q6. If you get a single dose that's too high, so more than 2 grams, you may actually give a smaller dose but more frequency in order to achieve the same daily dose. And then once you get the tau, then you actually calculate the dose that you want. And again, you use the same kind of peak based on your target trough in this equation. So this is the target peak that you want. And then once you get a dose and frequency, before you recommend it, but first of all, you want to round your dose to the nearest 250 milligram. But before you recommend your dose and frequency, you actually want to verify to see what would be the predicted peak and trough. You want to make sure that the predicted trough is the actual goal trough that you want. So you basically use these two equations to get that. Now, one thing that's different between vancomycin and aminoglycoside is that when you use the equation for dose, for the time of infusion, you put 1 initially because you have no idea what your dose is. So initially you just plug in 1 just to get the number. But once you actually calculate the dose, when you verify your peak and trough, for the time of infusion, you want to use the time of infusion that matches your dose. So for example, if you calculate the dose to be 2000 milligram, you want to use a time of infusion of 2. And that's because for vancomycin, you have to use the right time of infusion in order to avoid red man syndrome.